Now moving on to our fourth section, that is the amputation on the other sides of election, that is other elective areas where we can go for amputation. Sometimes we have to go for as a amputation as the first choice of surgery. We'll be briefly going through the amputations in the forearm, hand and hemipelvectomy, disarticulation through hip, transfemoral amputations, then knee, ankle, sign, spiragoffs and foot amputations. We will be briefly touching these different types of amputations, although there are a lot of indications and contraindications to these surgeries as well. So what are the other amputations? These include interscapulothoracic or four-quarter amputations. Although it's rarely done, and unless there, for example, a patient has synovial sarcoma of the scapula, and they may have progressed into a large mass, then we probably require this kind of a surgery only in that indication. Only for traumatic avulsion of the upper limb or eradicating a malignant tumor. As I just told you, this patient, if child has some kind of a synovial sarcoma of the scapula, this could grow into a massive tumor, and probably we require this kind of a extensive surgery to save the life of the patient rather than the limb of the patient, or as a palliation for pain. Then it could be the disarticulation at the shoulder joint. Although it's rarely indicated, but usually head of the humerus is left for the better functional aspect of the patient, holding the stump in the prosthesis. But it could be done, for example, depending upon the patient had an electrocution injury or patient had a fall from a high area and due to severe trauma a limb was not salvable, then probably this is the only indication where we have to go for this kind of a surgery, although it's rarely done and because the indications are quite rare. Then amputation in the forearm. The shortest forearm stump is 2.5 centimeter, in which the hand is actually, the forearm is cut just 2.5 centimeter above the wrist joint. Made from the front flexed elbow levels and useful as a hook to hang things from. But if the patient had some kind of a trauma in which there was a severe degloving injury of the hand and the wrist area, and any reconstruction is not possible, then probably this is the kind of a patient in which we can go for amputation in the forearm. Amputations in the hand is usually rarely done, but sometimes we may have to go for re-amputations in the metacarpophalangeal joints as well. And then coming to the hemipelvectomy or hindquarter amputation, it's actually rarely performed, and usually in the indication includes malignancy. As I just told you, this could be a chondrosarcoma of the hip joint or involving the iliac bone, which may be require hemipelvectomy, or intractable sepsis. Usually, although that is also rare, but septic hip joint could be highly problematic sometimes in the patients, especially once there could be some degree of problem since the childhood, and then eventually they go into adulthood, there could be a problematic hip joint, although that is a very rare indication for hindquarter pelvectomy. Then it is disarticulation through hip. That is, prosthetic fitting is very difficult because we need a very special kind of prosthesis, although this could be done, but in a very certain circumstances which may require this kind of surgery. Then tilting the table prosthesis can be fitted, but although that is, again, it has its own pros and cons, and then it sometimes can be very cumbersome for the child to put it on. Then disarticulation and molding of the torso is also a problem with disarticulation through hip joint. Therefore, usually this is highly rare surgery and rarely performed in patients. The most common is the transfemoral amputation or above knee amputation. Usually a longer stump gives out a better prosthesis control. Latitude is present as long as the amputated femur is at least 50 centimeter of the contralateral femur. The ideal length is 10 to 15 centimeter above the knee joint. So that actually puts that amputated femur is almost 50 to 60% or 57% of the contralateral femur. That is the ideal length. Although depending upon the situation, we may have to cut more femur, or we can still be able to preserve as much as femur as possible. Then around the knee, that is a gritty stroke operation is actually through knee surgery. That is actually disarticulation around the knee is done and the femur is completely preserved and tibia is actually amputated. It's good for the children because usually the prosthetic limb, which is actually the part which is preserved, does not grow out of the eventually the stump, and which later on does not create complication for the prosthesis, as well as does not require reamputation. End bearing stump is rarely satisfactory, but in adults this is a different problem. Usually this is above knee amputation has a better prognosis as compared to this critical stroke through knee disarticulation, and poor functional psychological outcomes, because usually prosthetic fitting is difficult to maintain in through knee amputation. Therefore it is more problematic for adults, but for children it's going to be a very good option for to use if amputation is actually required. Knee is grossly unequal in length, and that is why it's a problem. Stump length can be a problem as well, equivalent to above knee amputation. Then that is called as energy expenditure. If the length is preserved of the limb, then the energy expenditure is less. For example, energy expenditure of the below knee amputation is far less as compared to the above knee amputation. But the problem with this knee disarticulation is that although there's not only prosthetic fitting problem, but the energy expenditure of the patient is almost as much as above knee amputation, and with added on problem of prosthetic fitting. So probably if we are going for knee disarticulation, it's better to go for above knee amputation rather than going for knee disarticulation. If we cannot have below knee amputation, then probably the next best option is above knee rather than knee disarticulation. Then coming to the below knee amputation or transtibial amputation, it has actually the best prognosis. And why? Because it's a minimum energy expenditure increase in the body, although there is still, compared to the contralateral limb, there is some degree of increase, almost 40% as compared to the normal person. But the best part is that it has an excellent prosthesis available, and usually the prosthesis fitting and the patients are most satisfied with the below knee amputation. Nearly normal gait and almost 5 to 6 centimeter stump which is fitted with the prosthesis. Usually 8 to 10 centimeters on average minimum amount we have to take it up to 8 centimeters. Some books say 8, some say 5 to 6. So usually there is a consensus that some degree of tibia must be preserved so that the stump can basically fit in there. And usually greater length in the fitting is actually easier. If we are doing long below knee amputation in which a lot of tibia is actually preserved, it actually gives very excellent results, and even a smaller prosthesis is required, which can be easily managed. Now coming to the above the ankle or the Symes amputation. This provides a good limb circulation if the patient has limb is good, but the problem is below the ankle joint. Problem is at the foot level, then probably we do not need to cut all the way along the tibia. Probably the above ankle would be a good option. But distal physis is usually preserved. Few indication, that is the stump. The problem is the stump is end bearing and scar is brought away from the end. But the bones are actually divided above the malleoli and flap attached to the cancellous bone. But as the limb length is so good and there's very less energy expenditure, the problem is prostheses are not as good, or as the patient not as satisfied as with the below knee amputation. Then coming to the Pirogov amputation and amputation of the foot, although this is rarely done, but usually Pirogov amputation is actually tarsometatarsal amputation, in which if you see this, the through tarsi actually the amputation is done. Calcaneum and talus are preserved and other tarsal bones are actually removed along with the forefoot and midfoot. It's almost similar to Symes but rarely performed, and back of the os calcaneus is fixed onto the cut end of the tibia and fibula. Because of this whole foot is removed, then you require this to be fit back into the tibia. Therefore that will require some degree of Arthrodesis as well. The disadvantage is that it's actually midfoot and hindfoot disarticulation is actually not well maintained. The good part is you don't need a prosthesis, because this calcaneum is once fixed back, this can still act as a heel, and you do not need any prosthesis for the patient. But the problematic part is that actually eventually this actually puts the forefoot or midfoot into kind of a cavovarus equinus deformity, which is actually more problematic. In the foot, this could be through the base of the proximal phalanx, because usually this is kind of a form of a ray amputation, which is usually done in case of diabetic patients. Entire ray has to be amputated, And diabetic gangrene and septic arthritis are the common indications which this reamputation is usually performed. And this is only when single digit is involved. Multiple digits are involved, we may have to go for some kind of a tarsometatarsal or through tarsal amputations. Now coming to the partial front amputation. The problem is when Achilles tendon is present, this can put the patient into equinus, or that is into the plantar flexion. Similarly, the splintage and tenotomy and tendon transfer may be required because usually not only goes in equinus, they also go into cava varus deformity as well. Other options include Chopard, which is transmetatarsal amputation, or Lisfranc, which is tarsometatarsal amputation, which can also be done, but depending upon the indication whether it is required or not. And then it also has its own pros and cons, which has to be kept in mind. Adequate flap for the plantar skin is always and kind of a mandatory, and you must obtain it, because if this adequate flap is not possible, then bone will be exposed, get infected, and probably revision of amputation to a higher level may be required. Now coming on to the prosthesis. Upper limb distal portion of the prosthesis is usually detachable. It can be replaced by truss hand, and useful terminal devices have been developed before, so therefore especially forearm amputation have a very good outcome, activated by impulse detection in the stump muscles. Now coming to the lower limb, and the weight is transmitted through the ischial tuberosity, and then also by a patellar tendon in upper tibia soft tissue. If this patient now has gone under through below-knee amputation, the weight is transferred from the ischial tuberosity back into the patellar tendon, from there onto the prosthesis. But if usually the permissible combinations, there are multiple actually generations of prosthesis. There are old generation, the new generation. Newer generation have a more bodily kinematics as compared to the old one. And total contact self-suspending sockets have been actually developed, so that actually there is no stump pain and stump problems which may be associated with the older generation of the prosthesis. Now coming to the complication of amputation stumps. Every surgery has some degree of complication, similar as case with the amputation. Complications can be divided into early and late phases. Early includes breakdown of skin flaps, gas gangrene, although it's a form of infection, and late include basically skin problems, which could be desquamization, the prosthesis impinging on the skin, leading to some kind of a wound or problematic areas over there. Could be eczema or ulceration. There could be muscle problems such as squishing or feeling of insecurity. There could be blood supply problems with the stump. Could be poor, cold, or blue stump. Below-knee amputation of especially this problem. There could be nerve problems, especially in form of formation neuroma, which could be highly painful, or there could be even phantom limb syndrome as well. Or another common complication is the phantom limb syndrome, which is due to residual limb pain and depression symptoms, and difficult to treat, because usually when the nerves form a neuroma in and around the joint, what happens is the patient feels in the limb, pain in the limb which is being amputated. And for example, if a below-knee amputation was done for any reason, patient will come and complain of the patient, I am having a foot pain or ankle pain of the limb which is actually been amputated way back. But this is associated with depression. Usually it's very difficult to treat, but can be treated. And usually the meticulous handling of the nerves should be done during amputation, so that there's decreased chances of development of phantom limb syndrome. Other is associated with the joint problems, which could be stiff or deformed, or this could go into fixed flexion or fixed abduction at the contractures at the hip joint. Because if the patient post movement goes into resting phase and does not moves his or her limb post-operatively, this can go into contractures, and that has to be prevented by use of exercise. Other problems could be related to bone as well. That could be infection of a spurt enlargement, or it could be a fracture which needs fixation probably. In this section, we have briefly gone through the complications and other sites of the amputation. Depending upon the requirement, they may require in the shoulder, around the elbow, or in the forearm, or they may require hip disarticulation if they are suffering of some kind of a malignancy. Usually the most commonly performed surgeries are below knee and above knee amputation. They both have its own pros and cons, and we need to remember that if we're gonna preserve the length, that is gonna means that decreased energy expenditure for the patient. For example, the patient with a below knee amputation has higher energy expenditure than normal, but her energy expenditure is far less as compared to the patient with above knee amputation. So, but then again, with the higher the length is, for example, in case of SIME amputation, the length is very well preserved. But then there comes with the problem of the prosthesis fitting. So when we are performing the amputation, when we are deciding the level, we need to keep in the mind the energy expenditure of the patient and the problem of the prosthesis, whether we will be able to fit a good prosthesis this patient or not. Keep watching sqadia.com. Thank you very much.